with Ram kind of live, and then we will be talking about it. So good to have you. Today we are going to talk about the PGI session. So yes, I'm live, and let's begin our session for today. Okay. So right. So okay. So hi guys, welcome. Can I just have a thumbs up? Whoever is online, can I just have a thumbs up? Whoever is online, guys, can I just have a thumbs up? Am I audible and visible to you properly, guys? Right. So I can see that I have 7 members at this moment along with me. Just give me a hi, just give me a thumbs up. Right. So let's talk about this particular question, guys. Okay. So, right. Okay, fair enough. Let's talk. Let's first talk about this particular question. Now, right. The question is basically which of the following statements is true about the diaphragmatic injury? So this is a question on the diaphragmatic injury. Which of these following questions, statements, is basically true about the diaphragmatic injury? Can you please tell me? Can you please tell me what is the answer? Like, it is the most commonly caused because of a blunt thoracic trauma. Let us take up one statement at a time, okay? Let us take up one statement at a time. If I just talk about the first statement, okay, it is the most commonly caused because of a blunt abdominal trauma. Do you think it's a correct statement, guys? So, okay, can you please tell me, is it a true statement? Anybody, guys? So I can see that 2 of you have answered till now. Can you please tell me, is it a true or a false statement? Right. So all of you are for true. All of you are for true. Okay. Okay. So I can see that you're saying true, guys, but no, guys, it is not a true statement. It is a false statement. Okay, it is a false statement. It is not a true statement. Please understand why it is a false statement. Because it is not caused because of a blunt abdominal trauma, guys. It is mainly caused because of a penetrating abdominal trauma. Please understand, it is not a true statement. It is a false statement. It is not caused because of a blunt abdominal trauma. It is only caused because, like, it is most commonly caused because of a kind of a penetrating abdominal trauma. So let us jot down the important points about the diaphragmatic injury. So if we just talk about the diaphragmatic injury, okay, so if I just talk about the diaphragmatic injury, so it is more common with the penetrating as compared to that of a blunt abdominal trauma. Okay, penetrating, it is more common with the penetrating as compared to the blunt abdominal trauma. Now if I ask you, when will you suspect that this is basically, like, for example, if at all a patient comes to you, when will you suspect that the patient is suffering from a diaphragmatic injury? Can you please tell me? Anybody, can you please tell me when will you suspect that the patient is suffering from a diaphragmatic injury? Now this is a very, very important topic, okay? For the PGI, trauma is very important. So let us talk in a bit detail about diaphragmatic injury. When will you suspect when the patient is suffering from a diaphragmatic injury? So if at all the patient has a penetrating injury and the entry wound of this particular injury, the entry point, it is basically between the nipples and costal cartilage. Okay, so if at all the entry point is between the nipple and the costal cartilage, then you will suspect that the patient might be suffering from a diaphragmatic injury. Why? Because our diaphragm is always moving. Okay, our diaphragm is always moving, and you don't know when the patient was kind of penetrated with an object, whether the diaphragm was above or whether the diaphragm was down. Okay, so many of the patient, like the students, are answering that difficulty in breathing. Please understand, patient usually doesn't come with a difficulty in breathing. The most common presentation of the diaphragmatic injury, if I ask you, what is the most common presentation? The patient is basically asymptomatic. Okay, so please understand, usually the patients are asymptomatic. Okay, so huge patients are usually asymptomatic. Okay, usually the patients are asymptomatic. So please understand, the difficulty in breathing, that will not be a thing which on which you will suspect, because that will be present in maybe less than 5% of the patients. Only when the defect is large enough, then the difficulty in breathing will be present. But if at all you have a site of the penetrating wound, if at all it is between the nipples and the costal cartilage, then you will suspect the patient to be suffering from a diaphragmatic injury. Now, if at all you suspect the patient to be suffering from a diaphragmatic injury, how will you diagnose it? The next statement is basically the investigation of choice to diagnose this is an MRI. Is it a true or a false statement? Can you please tell me? So the investigation of choice to diagnose a diaphragmatic injury, it is an MRI. Is it a true or is it a false statement? Can you please tell me? So guys, please understand diaphragmatic injury is a very very important topic as far as the PGI is concerned. Now, I have one answer. Okay, so if at all that is a false statement, can you please tell me what is an investigation of choice? So you guys are absolutely correct. In fact, this is again a false statement. Okay, it is a false statement. So why it is a false statement? What is an investigation of choice? So please understand, investigation of choice in order to diagnose a diaphragmatic injury is in fact a laparoscopy. Okay, you have to go for a laparoscopy. You have to put in a scope and you have to see whether the patient is having a defect or not. So you can either perform a laparoscopy or you can have a VATS. Okay, so you will not directly perform an exploratory laparotomy. Okay, you will not directly perform a exploratory laparotomy. First you will have to perform a diagnostic laparoscopy. Okay, diagnostic laparoscopy, that is the first investigation, and this is basically the investigation of choice also. Okay, so please understand, investigation of choice is in fact a diagnostic laparoscopy. Now, next point is basically conservative management is preferred method of treatment. Can you please tell me, is it a true or is it a false statement? So conservative management, it is a preferred method of treatment. Is it a true or false? Can you please tell me? Conservative management, it is a preferred method of treatment of this particular patient. Can you please tell me, is it true or a false statement? If at all, let's say the patient is asymptomatic, patient has only 0.5 to 0.5 centimeter rent in the diaphragm, will you manage the patients conservatively? Yes or no? Can you please tell me, guys? Okay, please understand, conservative management, it is never a preferred. Okay, it is never preferred. It is also a false statement. You always and always have to go for a surgical correction. It is never ever preferred. Why? Why don't you prefer to go for a kind of a conservative management? Why don't you prefer to go for a conservative management? Because the diaphragm is not like skin. It will not kind of heal on itself. So what is going to happen over a period of time, the patient will come to you after let's say 5 years or 8 years or 10 years or something like that, and now the patient is going to have the herniation of an intestinal, like the abdominal contents inside the thorax, because over a period of time, let's say the defect at the time of the injury was 0.5 centimeters into 0.5 centimeters, and you were the basically treating physician and you basically left it like it is. You did not go for a surgical correction. So what will happen over a period of time, this particular small defect will enlarge and it will basically get converted into a big defect, a large defect, and because of this particular large defect, the abdominal organs like the intestines and the stomach, they might herniate into the thorax, and now the patient will come to you with a respiratory distress 4 to 5 years later. I hope you are able to understand this particular point. Okay, so please understand, conservative management, it is never a preferred option for the diaphragmatic injury. If at all you have a diaphragmatic injury, always and always and always you have to go for a surgical correction. Okay, right. Now, non-absorbable sutures are used in the treatment. So is it a true statement? Non-absorbable sutures are used in the treatment. Is it true or false? Can you please tell me? Non-absorbable sutures, will you prefer to? Okay, so you now know that you have to go for a surgical correction. So whenever you try to repair the defect, so will you use a non-absorbable suture or will you use an absorbable suture? Is it a true statement or is it a false statement? What do you think? Okay, I'm just waiting for a couple of seconds, then I'll answer. Can you please tell me? Okay, guys, please understand, this is in fact a true statement. Okay, so this is a true statement. You will have to use a non-absorbable sutures in order to manage a patient of a diaphragmatic injury. Please understand, it is a true statement. Anshu, it is a true statement, because whenever you kind of do a surgery in a patient of diaphragmatic injury, always and always and always you have to use a kind of a non-absorbable sutures. Okay, important point. Now, another point is laparoscopy is preferred over the VATS. Okay, so I did tell you that here you will have to perform a diagnostic laparoscopy or a VATS. Out of these, I'm trying to ask you which one is preferred. VATS is preferred or a laparoscopy is preferred. So please understand, I have already told you that investigation of choice is a diagnostic laparoscopy. So yes, definitely the laparoscopy is the preferred thing, and also that is a true statement. Okay, why so? Why do you prefer a laparoscopy? Why don't you prefer a VATS? Because there is a very high chance that whenever there is a diaphragmatic injury, maybe underlying intestine or a stomach might also must have got injured. So it is always a better idea to go through the abdomen so that you can also have a look at the stomach, you can also have a look at the intestine, because anyways you are trying to look at a rent in the diaphragm. Are you understanding my point? So these are all the important points regarding the diaphragmatic injury. It is a very very important topic. I'll just revise it in 1 minute and then we will move on to the next particular topic. So please understand diaphragmatic injury. What is it? So this is basically usually common after the penetrating trauma. It is not that much common after the blunt abdominal trauma. When will you suspect? Okay, so whenever the patient of a diaphragmatic injury comes, most of the times the patient is having a very very small defect. So most of the times patients will be asymptomatic. So if at all the patient comes to you, when will you suspect that the patient is suffering from a diaphragmatic injury? If at all the penetrating wound is there, so the entry point is basically between the nipples and the costal cartilage, then you will suspect that the patient is suffering from a kind of a diaphragmatic injury. And in order to diagnose this, you will have to go for a diagnostic laparoscopy because that is the investigation of choice. And if at all that is not possible, you have to go for a VATS. And if at all you have diagnosed the patient with a diaphragmatic injury, you never ever have to go for a conservative management. Always and always and always you have to go for a surgical correction. You have to go for a treatment with a non-absorbable sutures. This is also very very important because if you go for absorbable sutures, the patient, or if you don't kind of do the surgery at all, what will happen? The patient might come to you with a delayed presentation. After 4, 5, 8 years, patient will come to you with a herniation of the intestine and the stomach in the thorax, which is not a good thing. Okay, and between the VATS and the laparoscopy, definitely laparoscopy is the preferred method. Okay, so this is all about the diaphragmatic injury. It is a very important topic for the PGI. So I hope you got this. Now let us move and let's talk about the next question. Okay guys, let's move on. The next basically question is which of the following statement is true about the burst abdomen? So now we are going to talk about the burst abdomen. So can you please tell me, the first statement is basically the most common presentation is at the post-operative day 6 to 8. Can you please tell me, is it a true or a false statement? Okay, now before going for this, okay, now you guys please answer, I'll just clear it out. So one of the students is basically asking, investigation is not CT? No, definitely not. Please understand, for diagnosing a patient of a diaphragmatic injury, CT scan is not at all sensitive or specific. Please understand, even MRI is not sensitive or specific, because what is going to happen is, in your exam you will see that diaphragm is a soft tissue and it is very well engraved in your minds that MRI is the thing which you do for a soft tissue, and you invariably end up marking MRI as the answer. But please understand, MRI is not the investigation of choice. Investigation of choice to diagnose a patient of a kind of a diaphragmatic injury, it is in fact a diagnostic laparoscopy. I hope you get it. Okay, right. Now going to the next question, my first option is basically most common presentation of a burst abdomen is on post-operative day 6 to 8. So yes, that is a true statement. So guys, why so lethargic? Why are you guys not answering? Please try to answer, please try to cooperate, please try to put your answers in the comment box. It will be better. Okay, it will be better for me, also for you. Please do kind of answer. Right, so definitely the most common presentation of the the burst abdomen, it usually occurs on the post-operative day 6 to 8. That is the time period when the patient is at a maximum risk of this particular thing. Right, so I'll get back to you, Rohan. I'll get back to you. Let me just kind of go over this and then I'll get back to you. Right, now Salmon's sign is the first presentation of the burst abdomen. Is it a true or a false statement? So the second kind of option is Salmon's sign is the first presenting feature of the burst abdomen. So well guys, yes, it is also a true statement. Okay, so please understand, what usually happens is, let's say the patient was operated for a laparotomy or something like that, and the patient is in the wards, in the inside the wards. So what is going to happen on post-operative day 6 to 8? On post-operative day 6 to 8, what is going to happen? If at all the kind of the first year is going to do a kind of dressing or something like that, so what is going to happen? There is going to be a copious serous discharge from the wound. Serous discharge from wound. So is it a good thing? No, not at all. Because if at all there is this kind of a copious serous discharge from the wound on the post-operative day 6 to 8 after a laparotomy, this basically indicates that the patient is suffering from a burst abdomen. Are you understanding my point? So this is not at all a good sign. Okay, and this is basically the first presenting feature of the burst abdomen. Very very important. Okay, so the 2 points, they usually present on the post-operative day 6 to 8, and they basically present with a copious discharge, copious serous discharge from the wound site. Fair enough. Now the sheath of the abdomen is closed by the continuous manner. So you can take either a kind of interrupted sutures or you can take a continuous suture. What is the preferred method of closing the sheath of the abdomen? I hope you know that inside the abdomen you have the kind of a skin, then you have a soft tissue, and below this you below this you have the muscles, and below the muscles you have the sheath of the abdomen. So when you basically close the laparotomy wound, what you basically do, you first have to close the sheath, and then you have to take sutures over the muscles. So right, so can you please tell me what is the preferred method of taking the sutures on the sheath? Do you prefer to take a continuous suture? I hope you understand what is a continuous suture and what is an interrupted suture. So what I'm trying to ask you, will you go for a continuous suture or will you go for an interrupted suture? For this, you have to answer this. Okay, the sheath of the abdomen is basically closed with a continuous manner. Is it a true or a false statement? Can you please tell me? Prefer this continuous manner. Is it true or a false statement? Please answer, guys. Please answer. Interrupted. Okay, right. Anybody else? Can you please tell me? I want all of you to answer. Whether you like whatever you want to answer. I want all of you to answer. Guys, no, please understand, it is a true statement, okay? Please understand, this is in fact a true statement. It is preferred to take up a continuous sutures. Please understand, it is a direct line from Love and Bailey. Please understand, it is preferred to take up a continuous suture, okay? And that too, earlier we used to go for only and only Prolene, okay? So if at all I ask you what is the suture which you use for Prolene, for the sheath closure, you will invariably answer me as Prolene. It is not false, it is true. Prolene is basically most commonly used suture even today in most of the practices. But what the guidelines say, guidelines basically say that you have to use a delayed absorbable suture. Okay, so they say that you have to use a delayed absorbable suture. Absorbable suture. Okay, so what is this delayed absorbable suture? Can you give me an example of this delayed absorbable suture? Can you please tell me a delayed absorbable suture? Can you give me an example of a delayed absorbable suture? It is PDS. Okay, what is the absorption time of this? It gets absorbed in 180 days. Are you understanding my point? So this is a delayed absorbable suture. So if at all somebody says that Prolene is a good suture to kind of close the sheath, no doubt, it is a true statement. But what the guideline says that, guideline basically say that nowadays you have to go for a continuous suture with the delayed absorbable suture. Are you understanding my point? So you will have to kind of answer the particular MCQ depending on the options and depending on the framework of that particular question. I hope you get this, okay? Right. You will not use Vicryl, you will not use monocryl. Why? Because it will get absorbed very very soon and it will increase the risk of burst abdomen. But what they have seen is that as far as the burst abdomen as a complication is concerned, there is practically no difference between the PDS and the Prolene if at all the surgical techniques were good. But post-operatively, Prolene is a non-absorbable suture. It will always and always stay in the abdomen, so it might cause some discomfort to the patient after the healing has been done. But this particular comorbidity post-operative, it is not there with the PDS. Okay, so that is why nowadays they say that you have to prefer a continuous suture and that to a PDS suture. That is a delayed absorbable suture. I hope you understand my point. And yes, definitely continuous suture. Somebody is asking continuous suture, really? Yes, you have to go for a continuous suture in order to close the sheath of the abdomen. I hope you get this, okay? Alright, moving on to the next option. Emergency laparotomy is required for the management of the burst abdomen. Is it a true or a false statement? Will you try to go for an emergency laparotomy in here? So yes, emergency laparotomy is done. It is a true statement again, okay? So even this kind of D is a true statement, okay? You have to go for an emergency laparotomy in here, okay? Because if at all you don't go, patients might land up into peritonitis. If at all the intestines are kind of visible, what might happen? If at all the intestine is visible, the patient might undergo the necrosis and the gangrenous changes in the intestine, which is not a good thing, okay? So that is why if you have a burst abdomen, you have to go for emergency surgery if at all the kind of intestine is kind of visible or something like that, okay? I hope you got this. Now, the cause of the burst abdomen is always because of the poor surgical technique. Is it a true or a false statement? Now, I want all of you to answer that question number E, like option number E. Is it a true or is it a false statement? Is it always because of a poor surgical technique? Yes or no? Can you please tell me, guys? Is it a true or a false statement? So please understand, no, it is a false statement. It is not always because of a poor surgical technique. It can also occur because it is, in fact, most of the times, it is usually caused because of some or the other reason which is leading to the increased intra-abdominal pressure. For example, let's say the patient has ascites. Let's say the patient has a chronic cough. Let's say the patient is of COPD. Okay, so if at all there is a patient who is pregnant, if at all the patient is of COPD, if at all the patient has hernia, if at all the patient has bladder outlet obstruction, patient has ascites, or any other reason which is basically responsible for increasing the intra-abdominal pressure. Because of this, if at all there is an increased intra abdominal pressure. Okay, this is the reason for the development of the burst abdomen. Okay, I hope you got this. I hope you get this. Okay, so any reason which is basically leading to the increase in the intra-abdominal pressure, that will basically increase the risk of burst abdomen in these particular patients. I hope you got this. Fair enough. So the last statement is a false statement. Let's move on to the next question. So which of the following statements about the is true about the hiatus hernia? Okay, so which of the following is a true statement regarding the hiatus hernia? Type 1, most common type is the type 1 sliding. Okay, so let's talk about the option number A. Is it a true or a false statement? Can you please tell me? Can you please tell me, is it a true or a false statement? The most common type is type 1. Is it a true or a false statement, guys? I want all of you to answer. Can you please answer? Is it a true or a false statement? Right. So yes, it is a true statement. Okay. So guys, please understand, it is a true statement. The most common type is in fact a type 1 hiatus hernia. So this is basically a sliding hiatus hernia. Okay. So sliding is the most common type, and yes, that is a true statement. Fair enough. Now, what about else? Sliding hiatus hernia always requires a surgical correction. Is it a true or not? Right, definitely I can. I will definitely do that. And I think I did not answer one more question. Okay, so I think Rohan had asked me something. I am really sorry. I'll definitely do that. Don't worry. So what is the investigation process? Okay, I'll tell both the things. So okay, should I answer that first? I'll just complete this particular question and definitely answer back. Okay, so just wait. I'll definitely answer that. Okay. So what about the option number 2? Sliding hiatus hernia always requires a surgical correction. Is it a true or false statement, guys? So, right. So, can you please tell me, sliding hiatus hernia, does it always require a surgical correction? The answer is false. It doesn't require always a surgical correction. Please understand, sliding hiatus hernia doesn't require a surgical correction always. Okay, it requires. Okay, so let's talk about the sliding hiatus hernia. So hiatus hernia can be basically of the 4 types. Okay, it can be type 1, type 2, type 3 and type 4. So type 1 is basically a sliding hiatus hernia. Okay, so this is basically a sliding hiatus hernia. Okay, so this is a sliding hiatus hernia. Now if at all there is a sliding hiatus hernia, what it will present to you with? So what is going to happen in here? The GE junction will be moved proximally. The gastroesophageal junction will be moved proximally, and because of this, what will happen? These patients will present with GERD. These patients will present with GERD, and if at all they present with GERD, what will you go for? Will you go for treatment of these particular patients? No, not always. So if at all the patient is coming to you with GERD, the patient may either be asymptomatic or the patient can be symptomatic. So only if the patient is symptomatic, only then you will have to go for a the treatment. And even in the treatment, first you will go for drugs. If at all it is not helping, then you will go for a surgical correction. I hope you get this. Okay, so this is how you manage a patient of a type 1 sliding hiatus hernia. So they usually present with GERD. In the GERD, you will not kind of treat all the patients. Okay, if at all the patient is asymptomatic, just observe, no treatment required. So if somebody asks you what is the treatment for a asymptomatic GERD, nothing, no need to treat it. If at all there is a symptomatic GERD, then you will have to go for a drugs, that is a proton pump inhibitors, antacids, all those things. If at all the patient is not responding to them, or if the patient is still continuing the symptoms or something like that, then you will have to go for a surgical treatment. I hope you get this. Okay, so this is how you will manage a type 1 hiatus hernia. Now next kind of option is rolling hiatus hernia always requires a surgical correction. Is it a true or false statement, guys? Can you please tell me? So rolling hiatus hernia always requires a surgical correction. Can you please tell me, is it a true or a false statement? Yes, it is a true statement. Okay, so rolling hiatus hernia, it requires always a surgical correction. Why does rolling hiatus hernia always require a surgical correction? Because what is happening in the rolling hiatus hernia is, this is a diaphragmatic hiatus, and what is happening? This is your esophagus. The gastroesophageal junction is at a normal position, but a part of the stomach has entered into the thorax like this. Okay, so what is going to happen? This particular part of the stomach which has gone inside the thoracic cavity, this is always and always at the risk of the ischemic changes, gangrenous changes. Why? Because maybe this particular part of the diaphragm, it will pinch this particular part of the stomach, and this will lead to the ischemic and the gangrenous changes in this particular part of the stomach, and the patient might come to you with a perforation, and you don't want this. So even if you have a asymptomatic rolling hiatus hernia, you always have to go for a surgical correction in order to prevent that part of the stomach to undergo gangrenous changes and right, all those things. I hope you get this. Fair enough? Right. Now, okay, so basically this type 2 hiatus hernia, this is basically a rolling hiatus hernia. I hope you know this. So this is a rolling hiatus hernia, and this is basically in which the GE junction is at a normal position. Okay, so GE junction is normal. Now, let us talk about this fourth option. I want all of you to answer in this particular option. Okay, so GERD is associated with the type 3 hiatus hernia. Is it a true or a false statement? What do you think? Will type 3 hiatus hernia have GERD? Yes or no? Can you please tell me, guys? True or false statement? Can you please tell me? This option C, D, GERD is associated with type 3 hiatus hernia. Can you please tell me? Anybody else? Can you please tell me? Okay. Anybody else? Can you please tell me? Okay. Right. Now guys, please apply your logic. What is type 3 hiatus hernia? Can anybody tell me what is the type 3 hiatus hernia? So type 3 hiatus hernia is basically sliding plus rolling. Okay, are you understanding my point? So this is sliding plus a rolling hernia. Okay, fair enough. I hope you get this. Now, if at all it is a sliding hernia, what do you understand by sliding hernia? Sliding hernia is the one in which the gastroesophageal junction is basically moving upwards. Are you understanding my point? So, in the sliding hernia, what did we say? That in the sliding hernia, the GE junction will move upwards. So, if at all there is a sliding hernia component in this, will there be GERD associated with this? The answer is yes, guys. Okay, so they will come to you with the GERD. The only reason is it is also associated with the rolling hiatus hernia, and that is the reason why each and every patient of this particular type 3 hiatus hernia we have to operate. But yes, if somebody asks you, is GERD associated with the type 3 hiatus hernia, the answer is yes, because type 3 hiatus hernia is sliding as well as a rolling hiatus hernia. Are you understanding my point? Did you get it, guys? So till date you have only been asked whether it is associated with the type 1 or type 2. But if at all they say is it associated with the type 3, is it associated with the type 4? Yes, it is definitely associated with the type 3 as well as with the type 4. Okay? I gave you the explanation, I hope you will remember it. Right. Now GERD, okay, that's fine. And the Cameroons also aren't seen in the type 1 hiatus hernia. Okay? Okay, that is basically a kind of a stupid, it's basically autocorrect. The question which are basically, which I wished to give you was, Cameroons ulcer are seen in the type 1 hiatus hernia. The answer is false. So Cameroons ulcer are not seen with the type 1 hiatus hernia, they are basically seen with the type 2 hiatus hernia. So this particular part of the stomach which has gone up, so what can happen? Linear ulcerations can occur on this part of this stomach, and these are basically called as a Cameroons ulcer. I hope you get this. Okay, so these are the Cameroons ulcer which can be seen in the patients of a kind of a rolling hiatus hernia. I hope you got this. Fair enough. Now let me answer the questions which you guys were basically trying to ask me. So you basically asked me to label all the layers of the abdomen. Okay, so I'll definitely do that. So please understand, most inside what do you have? You have a peritoneum. Okay, so innermost layer is basically the peritoneum. Just outside the peritoneum, what do you have? You have the sheath of the abdomen. Okay, then you have the sheath of the abdomen. Then what you have? You have the muscle component. So you have this transversus abdominis, external oblique, internal oblique. So you have the muscle layer out of it. So here you have the muscle layer, and obviously in the between it is all going to be only a sheath, aponeurosis and everything. So I hope you understand this. Okay, so this is how it goes. Basically in the center there is a linea alba, there is a kind of a decussation of the sheath. So yes, in the center position there will only be sheath. Then over this what you get? You get the subcutaneous tissue. Okay, then you have this your campus fascia and those fascias, and then on the top you have the skin. Are you understanding my point? So innermost what do we have? Innermost you have the peritoneum, then you have basically the sheath, then you have the muscle, then you have the soft tissue or a connective tissue or a fat, whatever you want to call it. So this is basically a soft tissue, and then you have the skin. I hope you get this. Okay, so these are basically the layers of the abdomen. Did you get it, guys? Okay, I hope you get this. Somebody had asked me to mention the layers of the abdomen. I hope you got this. And another person had asked me something about the investigation. Okay, so just a minute. I'm trying to find the question. Okay, so what is the investigation process? So please understand, Rohan, when we were talking about the diaphragmatic injury, okay, so that was related to the diaphragmatic injury. So if at all somebody asks you diaphragmatic injury, okay, if somebody basically asks you what is the investigation of choice to diagnose, what is the answer? The answer is in fact diagnostic laparoscopy. Okay, so what is it? It is a diagnostic laparoscopy. I hope you got this. Okay, so if at all somebody asks you what is the investigation of choice to diagnose a diaphragmatic injury, it is in fact this diagnostic laparoscopy. This is an investigation. Okay, so I hope you were trying to ask me what is the investigation process. So this is also an investigation, right? Diagnostic laparoscopy, that is the investigation of choice. Okay, I hope you got this, right? So right, so this is all about the today's session which I wish to talk about. So I will again see you at 7 o'clock and I will discuss a couple of MCQs related to the AIMS pattern. We will basically meet again, but till then I just wish to talk to you about the basically our plus platform. So I will not repeat each and everything, guys, but yes, you do know that we have our plus platform in which we are basically covering lots and lots of structured courses. So we have a structured courses which are going on, and for the upcoming AIMS we have already launched the MCQ marathon, in which the 7 different types of the MCQs related to the AIMS are being discussed out there. Along with that, there are lots and lots of very exciting courses which are present on Plus platform. All I'll request you is just go on the link below. There is a link to my page. Just go there. Just have a look at all the courses which I have launched. And for this upcoming AIMS, what I am going to launch is for the upcoming AIMS. So what happens is most of the times students keep on asking me that what are the most important topics for surgery. So this time what I've decided is that I will cover a course on the most important topics in general surgery. Okay, so most important topics in general surgery. So I will be basically talking about this in 13 sessions. So I'll be taking 13 sessions. Each session will be 2 hours long, and in this I will be basically covering all the important topics of the general surgery. If you wish to be a part of it, it is going to be starting in the end of this month, and this will be basically ending before kind of next month. Okay, so I hope you might get benefited. If at all you wish to be a plus subscriber, please trust us, please come up and have a look at all the courses which we are launching. I hope you will kind of enjoy it, and if at all you decide to join any of the course, please consider using my promo code. My promo code is basically Dr.Pawan. So basically you can try to use my promo code. If you use this particular promo code, you will get around 10% discount on whatever things we are offering on this particular platform. Okay, I hope you get this. I hope you enjoyed this particular session. Please share it within your friends. Please kind of subscribe to our channel, and yes, thank you so much. I will again see you today at 7 p.m. We'll discuss a couple of MCQs related to AIMS. I hope you will enjoy it. Okay, thank you so much. It was indeed a pleasure. Have a great day. Bye. See ya.